So very good evening to everyone. Today we are starting off with the second half of the presentations after the sessions on the assessment in the CBME in community medicine. Now this time the presentation order has been reversed, and ours group, that means group J, that is Joyful Journey, will be the first to present. And now, being first to present always has its advantages and limitations. Advantages being more liberty to do things in a different way, and limitations being a lack of time for preparation. Now, we hope that we'll do justice to the presentation. And of course, this presentation will be itself a learning process. So let's begin the presentation by thanking our respected facilitators, Dr. Somdatta Madam, Dr. Animesh Jain sir, who have definitely guided us very well through this dark phases, and they were always present there for the help. Thank you so much, ma'am. And the participants which made the journey joyous for us includes Dr. Neha Agrawal from Meerut, Dr. Rupesh Sahu, that is myself, from Sagar, Madhya Pradesh, Dr. Manjurani from Jaipur, Rajasthan, Dr. Sanjeevani from Pune, Maharashtra, Dr. Tiku Sinha from Jagdalpur, Chhattisgarh, Dr. Renuka from Mysuru, Dr. Sandeep from Nalgonda, Telangana, Dr. Ishan from Narsinghpur, Madhya Pradesh, Dr. Jayashri from Dahoud, Gujarat, Dr. Kamna Singh from Katwa, Jammu Kashmir, Dr. Pankaj Gupta sir from Jhalawar, Rajasthan, Dr. Manisha ma'am from Amritsar, Punjab, Dr. Shalini from Mumbai, Maharashtra, Dr. Christina Paul from Chennai, Tamil Nadu, Dr. Amita ma'am from Jaipur, Rajasthan, Dr. Priyadarshini from Andhra Pradesh, and excuse me, slides are posing a problem for me. Yeah, Dr. Bhavna from Jammu, Dr. Akhil from Rajasthan, and Dr. Muhammad Abdul Mushtaq Pasha from Andhra Pradesh. So our presentation is basically divided into 4 parts as per the assignments. The first assignment was for having tools of formative assessment. The second one was for assessment of knowledge, that means the set of questions. The third is WPBA, that means workplace-based assessment for internship. And fourth one is the logbook. So let's start with the first assignment, which was given on the 6th November. Myself will start with this assignment, which was directed towards having a toolkit for formative assessment in community medicine. Now, the task was to identify formative assessment tools for community medicine vis-a-vis large group sessions and small group sessions. So in the new CBME curriculum, extended emphasis has been put on the formative assessment rather than summative assessment. So formative assessment is all about regularly getting feedbacks as to where the student stands and gives a way to the teacher to know what else has to be done to achieve the learning goals or the objectives. So there's always a search for the methods or the tools for formative assessment. So if we consider the large group scenarios, then the formative assessment tools for these both large and small groups, we have divided into 2 parts for presentation. That means those formative assessment tools which can be done through discussion and those which can be done through observation. So first, let's look at those which are through discussion. So whenever we speak of assessment, the first thing comes in mind is questions. So questions can be effectively used as an assessment tool in various forms. And the most common form of questions which can be used and which is being used are the MCQs. Now, MCQs can be posed individually or in group as well. So in group, we may divide the class in 2 or 3 groups and asking 3 or 4 MCQ questions to each group. It would be like a quiz contest. Another being the case-based MCQs, which can be very effective. Then we have the pre-test and post-test questionnaire. Usually we see these questionnaires in a workshop. In fact, in this workshop as well, we had a pre-test questionnaire. It can also be utilized for a large session for formative assessment. Now, strategically asking higher order questions, that means the whys and hows, definitely puts students in a state of mind that requires more attention. So it can basically help us to get those students who are basically putting on more minds or more efforts for this. The true false question formats is the another format. Quizzes and polls. Quizzes and polls basically is a kind of technique which help us in real time to figure out the shortcomings. Now they can be created with various of the web applications available like Socrative, Quizlet, or it can be played in the form of games like as we have discussed already, like Kahoot, Mentimeter, Flip Quiz, Quizaliz, and there are many kind of web applications, and they are also very effective in knowing the current situation of the student. Now, another is a 1 minute paper in which the student is basically asked at the end of the session to answer a few questions like what was the most important thing you learned in the session, what questions remained unanswered, and summarize the main point of that day's lecture in one sentence. So we may change the questions as to our settings or whatever we want. Now, another thing is one sentence summary, which can already be included in 1 minute before it can be taken otherwise as well. Now, other thing is the muddiest point, which have already been quite focused on. So the student is basically asked to enumerate that point which was quite confusing for him or her in the lecture. Another technique is directed paraphrasing. That means the students summarize in well-chosen words, basically their own words, the key idea which is presented during the class. Another technique is entry question and exit slips. Now, it's a good idea to start the class with a quick revision about the previous lecture. Now, alternatively, we can ask the students randomly to recall one important point from the previous session. I myself have done this and found this method quite effective. Um, the other thing is exit slip. At the end of the session, we can ask the student to submit a slip which is having the answer to the question, what is the gist of the lecture? So again, it summarizes the whole of the lecture in 1 or 2 sentences. Now these slips can later be sorted into 3 things like got the point, sort of got it, or didn't get it. So looking at the proportion of these things, the teacher may decide what he has to do with the topic. Whether he has to take it once more or put those points on once more, or is it sufficient? Another thing is self and peer assessment. Self-assessment basically more part of the self-directed learning. Another technique is misconceptions and errors. Now here the students are presented with common misunderstanding and they are basically asked to apply their previous knowledge to correct the mistake, or they can be asked to decide if a statement contains any mistakes at all and then discuss their answer. Now this can be a very effective method. Another technique for large group session is a 3-to-1 technique. Now this technique states that at the end of the lecture, the student is basically asked to compile 3 things about from the lecture, uh, three three things they learned from the lecture, 2 examples of how they can use the ideas they learned in the session, and one unresolved area or the muddiest point. Now we can have different sets of this 3-to-1. Now the one which I just read out, another can be 3 things you found out, 2 things, 2 interesting things, one question you still have, or another thing can be 3 differences between whatever the topic that is, 2 effects of dash on dash depending on the topic, and one question you still have about the topic. More things like 3 important facts, 2 interesting ideas, and one insight about yourself as a learner. 3 keywords, 2 new ideas, and one thought to think about. Or write 3 questions about the text, or write 2 predictions based on the text, and make one connection based on the text. Now there can be so many variations of this 3-to-1 technique depending on to the domain which we want to assess. Another form of summarization is that newspaper headline. in which the students are asked to create a newspaper headline that may have been written for the topic they are studying and submit either electronically or in chats. Now, this basically captures the understanding of the main idea of the event. Now, the another set, this was the set which was assessed through discussion. Now, through observation, we can have the checklist in which the following criteria can be considered, like the attendance of the candidate, the punctuality of the candidate, the participation in the class, the classroom behavior, the communication, and the dress code, and many more things can be included in this checklist. Well, last but not the least, it is not only the students whose formative assessment needs to be done, it's the teachers also whose formative assessment needs to be done. And it needs to be anonymous basically. Now it can be done through various platforms or various web applications, but I find this Google Forms very convenient for this. So anonymous feedback through Google Forms, like about what the students liked about the lecture and what they disliked about the lecture, what things they think should be improved, or what was the session at the correct pace, or was the language comprehension understandable. I have been trying this method for the last 3 sessions I have been teaching. So here are the responses from my students. So here we can see that the students are very observative and they are very keen to notice various small things as well. So apart from showing the good things in the lecture, which motivates the teacher, they also show us the shortcomings, like use of projector. Many of the students dislike the use of PowerPoint presentations, the project in that sense, and something the feedback like more than 1 hour lecture. After 1 hour, they get tired, also like that. And this is another slide, except from the same feedback I have presenting. Here we can also that the students can be very elaborative as well. If given an option of anonymity, they usually express whatever they feel is good. So they here one student is trying to say that what things I asked what things you disliked in the lecture and would like to get omitted in the future presentations. So he said the useless part. That means I mean everything is given in the book. So we come to class to know exactly what we can't gain from the books or important point that we used to avoid or ignore as we routinely read that out. So also we can see that another feedbacks can be given like please add more multiple choice questions related to the topic at the end of the lecture. We enjoyed 1 or 2 lectures where we had MCQ session, and thank you for those extra points. So a student can be very beneficial as far as the teacher's formative assessment is concerned, and once the teacher knows his shortcomings, he would be able to focus on that and be improve on that. Now, if we see the formative assessment in the small group sessions, now again they have been divided into either through discussion or through observation. So through discussion, the methods include the seminars, the case presentations, short or long, the spottings, viva voce with the feedback. And if we see the observation, the majority of the methods are through observation. So very well known methods like DOPS, OSPE and OSCE, mini clinical examination, checklist being the same which we have just discussed. And very well known is reflections, the Osler, the logbook, portfolio. Fishbowl technique, apart from being a teaching learning technique, can also be utilized as a formative assessment tool. Now, clinical work sampling, in which the assessment is done at the time of actual performance by multiple observers. 360-degree evaluation. Now, one interesting technique I found out while I was looking for the formative assessment tools is the inside-outside circles. Now, in this, the students in the small groups are made to stand in 2 circles, the inner circle and the outer circles, and the students face each other. And within each pair of facing students, they quiz each other. And they quiz each other with the questions they already have written. So the other student answers the question, and the outside circle, after asking one question, moves by 1 point, so that a new pairs are formed, and the process continues. Another important technique or interesting technique, I must say, is that I have the question, who has the answer? In this, the teacher makes two sets of cards. One set of cards contains the questions related to the topic, and the second set contains the answers to the questions. Now, the teacher may distribute the answer cards to the students, and the question cards may also be distributed or can be kept with the teacher himself or herself. So the students, if the cards are distributed, the students check their answer cards to see if they have the correct answer once the question is asked. Either the teacher asks the question with a card or the student themselves asks the question with a card. So those students having the answer to that particular question will prompt and say that I have the answer. Now the example to this can be stages of the demographic cycle, like high stationary. The question card contains the high stationary, low stationary, or early expanding, and the answer cards may contain high birth rate, low birth rate, birth rate and death rates, and accordingly. So this can be utilized in that way. Another important, interesting technique is one question and one comment. The students are basically assigned a chapter or a part to read, and they're asked to create one question and one comment generated from the reading. In class, the students, when they meet either in small or the large groups for discussion, then each student shares at least one comment or question. Now, as the discussion moves student by student around the room, the next person can either answer the previous question or can respond to the comment or share their own comments and questions. Now, when this activity builds up around the room, the conversation becomes in depth with the opportunity for all the students to learn new perspectives on the text. Now, these were all about the formative assessment tools. And one advantage with these formative assessment tools is that apart from serving as an assessment tool, they also act as a teaching learning method and motivates the student to do more, and sometimes in a fun way. So that's all about the formative assessment tools. I now invite Dr. Manisha Nagpal with assignment 2. Thank you.
Thank you, Dr. Rupesh. Am I audible?
Yes, ma'am, you're audible.
Okay. Good evening, everyone. So I'm going to present the next assignment that was given to us on 10th November 2020, that is assessment of knowledge. Now, as we all know that internal assessment in community medicine includes, we have in theory 4 internal assessments with the prelim exams that come at before the university examination. And for practicals, we have practical examination in first and second year. Plus, we have 2 clinical postings. First one is in first prof, and at the end, we have the exam for that. And second clinical posting in second prof, and we can have term ending exam at the end of second clinical posting. Then we have family health study and logbook. Now all these will be include, as we know that they all cover the cognitive domain, but along with that they also cover the psychomotor and non-technical skills like communication, professionalism, and teamwork also. So the assignment that was given to us about this was create following type of questions from among the competencies allotted to the group. First was long answer question, next was short note, then scenario based short answer question, and next one was scenario based MCQ. So one of the competencies that was allotted to our group was CM 9.1, which states that define and describe demography, demographic cycle, and vital statistics. The SLOs created for the competency was at the end of the session, phase 2 MBBS students should be able to discuss demography and the 5 demographic processes. Domain is knows and level is knows how. Then describe the 5 stages of demographic cycle and give examples using countries that belong to each stage. Again, domain is knowledge and level is knows how. Third SLO was describe demographic indicators and list the various population statistics and vital statistics. Again, domain is knowledge and level is knows how. And the assessment methods include long answer questions, MCQs, and short answer questions. So the long answer question our group created was based on SLO 9.1.2, which says that describe the 5 stages of demographic cycle and give examples using countries that belong to each stage. So the scenario created is the population of country X in the past decade was 2 crores and the population of the current country currently is 2 crores 30 lakhs. The birth rate and death rate of the country in the past decade was 20 births per thousand population and 18 deaths per thousand population respectively. And currently, the birth rate and death rate of that country are 20 births per thousand population and 14 deaths per thousand population respectively. And the questions that were asked to the students are: number one is identify the stage of the demographic cycle of the above country falls in with reasons, which carries 2 marks. Then briefly discuss the various stages of demographic cycle, which carries 4 marks, and give example of one country in each stage, which carries 2 marks. So no doubt, previous slide, Dr. Rupesh. Huh. So no doubt here, when we create a scenario and give the birth and death rate to the student, they can interpret or analyze the condition and then they will give the following answers. So it no undoubtedly this covers the higher level of learning. Next slide, Dr. Rupesh. Now, the other competency that was allotted to our group was CM 10.2, which states enumerate, describe, and demonstrate the methods of screening high risk groups and common health problems. So, at the end of the session, phase 2 MBBS students should be able to describe the risk approach in maternal and child health. Domain is knows and level is knows how. Then second SLO is enumerate the risk factors and their associated common health problems in a pregnant woman. Domain and level are knowledge. Then is demonstrate the screening method to identify high risk cases among the antenatal mothers attending antenatal OPD in the Rural Health Training Center. Here the domain is attitude and communication and level is shows how. Then the fourth SLO is identify correctly the high risk antenatal cases in the community. Domain is skill, attitude, and communication, and level is shows how. Next slide, Dr. Rupesh. So we created the short note based on this competency. It was it is how the maternal and child protection card can be used as a screening tool for the following. That is early identification of high risk pregnancy, which carries 2 marks, as a managerial tool, which carries 1 mark, and identification of malnutrition in children, which carries 2 marks. Again, based on this, the student will try to he or she may will be having the depth knowledge of the what he or she is reading in the RCH program. So next slide, please. The next question that was created was scenario based short answer question from the same competency. The scenario created is you are a medical officer in primary health center and a female named Rama who is 32-year-old reports with 4 months amenorrhea and urine test for pregnancy positive. She is primary gravida and on examination her weight is 60 kg, pulse is 80 per minute and blood pressure is 150 by 96 millimeter of mercury. Now, the questions that were created are: what are the lab tests you will advise for this case, which carries 2 marks? And what are the early danger signs and symptoms that you will advise her to look for so that she can report to the primary health center on time, which carries 3 marks? So, scenario based short answer question again go to the higher level of learning for the students. They'll read the case, they'll come to know about the high risk things that are present here and how will they will interpret what could be the diagnosis, and then they will answer this question. Next slide, Dr. Rupesh. Now, another competency allotted to the group is CM 9.4, which states that enumerate and describe the causes and consequences of population explosion and population dynamics of India. The SLOs created for this competency are: at the end of the session, phase 2 MBBS students should be able to, number 1, describe population explosion, which domain is knows and level is knows how. Then discuss the causes of population explosion of India, domain is knows, level knows how. Again, third SLO is discuss the consequences of population explosion of in India and discuss the population dynamics of India. In both the cases, domain is knowledge and level is knows how. And these can be assessed by MCQs, long answer questions, short answer questions. Next slide, Dr. Rupesh. Now, we created the scenario-based MCQ. This is that following are the 8 sex pyramids of the countries A, B, C, and D. Carefully observe these 8 sex pyramids, go through the statements given below, and choose the correct response from the alternatives. Next slide. Yes, these are the countries A, B, C, and D, and the 8 sex pyramids for them. Now the statements are somehow A, B, C, D is gone in the picture. So first one is A, B, C, and D. Statements are: country B has the maximum young population. Second statement is country A has the highest birth rate. Country D has the maximum old age population, and country C has the maximum life expectancy. And the alternatives given to this for this were: statements 1 and 2 are correct, statements 2 and 3 are correct, and statement 3 and 4 are correct, and D is statement 2 and 4 are correct. Now, as we were told about the types of MCQ, so this is the fits in the multiple completion type, and we have created that scenario so that they can analyze the situation, see the situation, and study the 8 sex pyramid, and then they will interpret what could be the right statement for this. Next slide. So this one is the answer for this, and they can interpret with the uh, diagrams that are given here. So thank you, and now I invite Dr. Christina to speak on workplace-based assessment. Thank you.
Thank you, Dr. Manisha. Am I audible?
Yes, Dr. Christina, you are audible.
Thank you, Dr. Manisha. So many assignments were posted on 17th November, and the assignment that was given to our group was create a workplace-based assessment for interns. So after extensive research, we narrowed down on 2 tools. One was the mini clinical evaluation exercise, and the other was the DOPS procedure. Okay, so this mini CEX was designed by the American Board of Internal Medicine, but it usually involves multiple encounters, multiple skills, and also multiple SSRs. Given the paucity of time, we decided on planning a DOPS station for our group. Next slide, Dr. Rupesh. Yeah. So DOPS stands for Direct Observation of Procedural Skills. It is an assessment method that was designed by the Royal Medical College of England for assessing clinical skills. It is a method in which the examiner observes the trainee during a routine procedure on a real patient and in a real situation and gives feedback to the trainee. Now, this can be done in a simulated environment also. Because of certain special features, such as valuable educational effects and timely and immediate feedback, it can be used for all levels of clinical education, and it is mainly used in residency programs. Next slide. Okay, so as per the recent NMC document, an intern must be able to identify common ailments and advise primary care. Now, this is the very first point that is given for interns in community medicine. So now diarrhea accounts for 13% of deaths in Indian children, though it is a treatable condition. An intern must be familiar with the assessment of dehydration so that she can plan and manage dehydration if any. Next slide, Dr. Rupesh. And as we all know, interns have 2 months of postings in the Department of Community Medicine, during which they are posted in the Rural Health Training Center and Urban Health Training Center. I'm sorry? Okay, so a DOP
Yeah, you
station.
please go ahead.
Yeah, I'm sorry. Yeah, thanks. So a DOP station on the assessment of dehydration will be developed in consensus with the departmental faculty. The DOPS rating scale that will be used for the assessment will be pre-validated, after which it will be used to assess the interns. Now, the interns during their postings in community medicine should either assess dehydration in an actual case of ADD in the under 5 age group or a simulated case of acute diarrheal disease in the under 5 age group, which will be made a mandate for completion of postings in community medicine. Next slide, Dr. Rupesh. So this is a fictional DOPS rating scale that we've designed for assessing dehydration in the under 5 age group. Now, if you see, it has many variables. To be precise, it has actually 13 variables. Now we've categorized them into 3 categories. One is if it's not done or done incorrectly, they get 0 points. If it's done correctly, but the interpretation is not correct, they get 1 point. If it's done correctly and interpreted correctly, they get 2 points. Okay. And for each criteria, there's also a feedback column for the observing faculty. Now, the very first point is self-introduction. Now, let's say the intern has not introduced him or herself. They get 0 points. Now, they just stated their name, but they fail to mention the face or their department that they're representing. They get 1 point. Now, they've done both their name as well as their department and face, so they get full 2 points. Statement of purpose. Now, if they have not mentioned why they're examining the child, they get 0 point. Now, if they've done it in a haphazard or partial manner, they get 1 point. If they've completely explained as to why they're assessing dehydration, they get full 2 points. Now, next is obtaining verbal consent from the guardian. Now, since we've already covered statement of purpose, here they either get the consent or they don't. So there's no 1 point here. So if they don't get the consent, they get 0 points. If they get the consent, they get 2 points. Now, if they've asked for history of increased thirst, that is, if they've not asked for it, they get 0 points. If they've asked for it, but they're not able to interpret the history properly, they get 1 point. If they've asked and they interpret the history correctly, they get 2 points. Now, the next is history of decrease in urine output. Now, I also request you all to notice that I've highlighted some of the criteria in red. I'll talk about the significance later on. So now, if they've not asked for history of decreased urine output, they get 0 points. If they've asked for it, but they're not able to interpret the history correctly, they get 1 point. If they've asked and interpreted correctly, they get 2 points. And also history of significant weight loss after this current episode of acute diarrheal disease. If they've not asked for it, they get 0 points. If they've asked for it, but they're not able to, interpret it correctly, they get 1 point. If they've asked and interpreted it correctly, they get 2 points. Now, so far was the history component. Now let's go on to the examination. So on observation, looking for appearance changes such as sunken eyes, absence of tears, irritability, and drowsiness. If they haven't looked for it. Now, as they're examining the child, they'll also have to simultaneously talk about their interpretation and what they're looking for. So as they're commenting, so you'll know if they've actually looked for these signs. So if they've not looked for it, they get 0 points. If they've done it, but they're not able to interpret it correctly, they get 1 point. If they've done it correctly and interpreted it correctly, they get full 2 points. Now, next is examination of the tongue for dehydration. If they've not done it or done it incorrectly, they get 0 points. Done correctly, but interpretation is wrong, 1 point. If they've done it correctly and interpreted it correctly, they get full 2 points. Then examination of radial pulse, not done, 0 points. Done but not interpreted correctly, 1 point. Done and interpreted correctly, 2 points. Measurement of blood pressure, not done, 0 points. Done but not able to interpret the reading correctly, 1 point. Done and interpreted correctly, 2 points. Examine for skin elasticity, not done, 0 points. Done but not interpreted correctly, 1 point. Done and interpreted correctly, 2 points. Okay, the final grading of dehydration with justification, if they were not able to come up with a final grading, they get 0 points. If they came up with a final grading, but they're not able to justify it properly or their interpretation is not correct, they get 1 point. They've done the final grading correctly, their interpretation is also correct, they get full 2 points. Now, If we stop here, this is 12 criteria, and the maximum marks for each of these criteria was 2. So that will amount to 24 points. But if it's an infant with an anterior fontanelle open, they'll also have to look for depression of the anterior fontanelle. So the 13th criteria only applies to infants whose anterior fontanelle is still open. So examination of anterior fontanelle, if applicable, not done, 0 points. Done, not interpreted correctly, 1 point. Done and interpreted correctly, 2 points. So if this criteria is also present in that particular case, they'll get 26 points, which is the maximum score. Next slide. Next slide. Yeah. So the final decision, passing minimum for the station will be set at 60% of the maximum score, along with no zeros in the mark criteria. Now, I would like to go back to what I said earlier. You would have noticed that I had highlighted some criteria in red and marked it with an asterisk. Now, those were the mark criteria. Now, the rating scale is completely within the jurisdiction of the departmental faculty or the one who's designing this DOP station. So here I had highlighted some criteria. So if they get zeros in the mark criteria, even if they get 80% overall, they still fail the station. Okay, so they can get a 1 or 2 in the mark criteria at least. Okay, and the passing minimum is 60% of the maximum score. So both of this should be present for them to clear the station. So verbal feedback on all the observed flaws will be given by the in charge faculty, and a written form with a score and a summary of the feedback will be given to the student at the end of the session. If the student has not passed in the first attempt, a repeat attempt will be given after the feedback session, and she will be allowed some learning time before the repeat attempt. Now, if the student has not passed during the repeat attempt also, then she will be made to complete the activity with the help of the facilitator and then again independently. Now, this is the end of my assignment. Now, I invite Dr. Neha to present her entry in logbook of a competency. Thank you very much.
Hello, good evening, everyone. Am I audible?
Dr. Neha, you're audible.
Okay, so a very warm good evening to all. So the last and the final assignment that we received was to choose a competency to document in the logbook. Next slide, please, Dr. Rupesh. So this is a sample lesson plan for the logbook activity that we have chosen. So the activity that we chose is for MBBS Phase 2 students, and it has been planned for 3-hour duration and for 25 students. The topic that we've chosen is environment and health, and the competency is 3.7, which says identify and describe the identifying features and life cycles of vectors of public health importance and their control measures. Next slide, please, Dr. Rupesh. The specific learning objectives of this competency are: at the end of this session, phase 2 students should be able to 1. Identify the common vectors of public health importance, 2. Describe the different stages of life cycle of common vectors, and lastly, describe methods of controls of vectors of public health importance. Next slide, please. So we have planned the activity for the first solo only, that is identify the common vectors of public health importance. Also, the activity includes identification of the 3 common mosquito vectors, that is Aedes, Culex, and Anopheles. And we felt that they are very easily found in our surroundings and are responsible for quite a few diseases. So the activity will be identify and describe the identifying features of common mosquitoes, that is Aedes, Culex, and Anopheles. The activity will include a pre-session activity in which the students will be asked to look for 3 breeding sites in their surroundings, click its picture, and then bring these pictures to the class. And if it is possible, they should bring it in print form. So during the session, the students will be given 15 minutes time to study the slides of adult male and female Aedes, Culex, and Anopheles. Then in the next 20 minutes, they will be asked to write down the identification of the slides with its identifying features. Next slide, please, Dr. Rupesh. Lastly, the students will be asked to present the pictures that they took previously and explain what they were able to decipher from it. Also, they will be provided with some pictures like maybe the larva of Anopheles or the eggs of Culex or the mouth parts of Aedes, whatever the facilitator may feel like. And then the students will be asked to identify the possible genus of the mosquitoes or the probable tribe, that is maybe Anophelini or Culicidae if they cannot identify the genus per se. So this 5 minutes will be given to every student for this activity, which will amount to around 1.25 hours. The last 20 minutes will be for feedback and discussion on all the slides and the pictures. Next slide, please. So the activity will be considered as successfully completed only when the students fulfill the following two criteria. Firstly, they should be able to identify the slides of the adult and female Aedes, Culex, and Anopheles, and they should write the identifying features of all these three male and female mosquitoes. The numerical scoring of the activity will not be required, but the documentation in portfolio and logbook will be required. In case the students fail to complete the activity in their first attempt, then they will be provided feedback along with corrections, and they will be given 2 more attempts to finish this activity after a certain amount of learning time. So if the students do not pass even after 2 more attempts, then they will be made to complete this activity with the help of the facilitator, and they can again then take the activity independently. So this is how the logbook entry of this activity will look like. So the competency address is 3.7. The name of the activity is identify and describe the identifying features of common mosquitoes, that is Aedes, Culex, and Anopheles. So supposedly the activity will take place on 19th of February 2020 or 21, sorry. It will be the first attempt. The rating, I've designed it as if the student failed to achieve this. So below expectation. So the decision of the facilitator will be to repeat the activity. He'll be provided feedback in the form of, say he failed to identify Culex and Anopheles, and he'll be advised to read more about the identifying features of Culex and Anopheles. So he'll be provided some learning time, and then again, the student retook the activity on 26th of February. So it was a repeat attempt. So this time he was able to complete the activity. So he met the expectation of the facilitator. So the decision of the facilitator was, okay, this activity is complete. And he received feedback in the form of satisfactory completion of the activity. And maybe he was advised to be more attentive in his further classes. So thank you. This was all on our side. Over to Dr. Christina ma'am for the final words.
Yeah. Thank you, Dr. Neha. So on behalf of our team, Joyful Journey, we express our heartfelt thanks to Dr. Sanjay Bedi for bringing us all together, making the impossible possible, bridging the gap between our regional and language differences. Thank you, sir, for choosing the best set of facilitators to run the program and making it a memorable one for all of us. Next, we would like to sincerely thank Dr. Somdatta Bhatra for being there throughout and for molding us. Her patience, kindness, and sincerity are truly remarkable. We also take this opportunity to express our gratitude to Dr. Animesh Jain, who, in spite of his busy schedule, has played an integral part in the making of this presentation as well as in the program as a whole. It has been a very joyful journey indeed. If you had seen our first slide, you would have seen a clueless biker embarking on a long journey. And if you had seen our last slide, now we have the satisfaction of having reached the top of the cliff, though we have miles to go. We bid farewell to all of you, wishing the forthcoming team presentations the very best. Goodbye. Thanks to one and all. Let the joyful journey continue. Thank you.
So thanks team Joyful Journey. It was really wonderful presentation, and also many thanks for the nice words. So I Thanks, Dr. Rupesh. So I don't see any questions in the question box. So I request the participants to type in the question box, like whatever the question you want to ask the speakers, today's speakers. And if anybody wants to speak, wants to share or something, the participants, you can express that and can use the hand raise option. We'll try to unmute and let you talk. And like the slides, Dr. Animesh and I myself, we actually were involved with the presentations. So may I request other facilitators, like by the time we get the questions from the participants, for their comments, questions for the presentation or to the speakers? Dr. Pankaj
Madam
sir, can I
Pankaj.
have your comment?
Madam, actually I joined slightly late, so I was not there for initial thing. I just want to know on the honest level from the group is among all these assessment methods what they have talked about. I could see one which was for internship, which was skill based at the health center, or it can be done in the OPD or a teaching hospital, depending on if the department is running the OPD or something. What were the other skills which were either OPD based or IPD based or admitted patient based or in the field? Because some of the skills are so-called intellectual skill I could see, but I want to know what are the other things they are looking for. Otherwise, what will happen is uh, community medicine will become a subject thing which can be taught in the demo halls and the lecture halls only. So just want to know, because I might have missed one. I could see was internship, other I am not aware because I joined late. Second question related to now very nice way of assessing things, and how much of this assessment I can implement in couple of months together when the present batch comes or the new batch comes, to be a practical honest answer from the participants or the group who presented. Why I'm asking this question, because that only lies into the purpose of this program. Otherwise, our fortunately or unfortunately, we are good in developing curriculum, programs, policy nicely on paper. But when it comes to implementation, unfortunately, we are not doing the right job. That is the reason, just to ask their frank opinion and honest opinion on those things.
Thank you, sir, for your honest question. So if you want an honest answer, now this is Dr. Christina. So as you said, looking at all these, titles is easy, but implementing all of them is not going to be an easy task. So in my opinion, for us to familiarize ourselves with all these different methods, I think it will take almost a decade. So till then, it will be baby steps. It's going to be a learning curve. It's a very long learning curve ahead of us. First is training the faculty, then implementing all these methods and making sure that everyone gets familiar and comfortable with these methods. It's going to be a very long process. But thanks to the wonderful program that's been organized, we are also, definitely way more familiar with these terminologies, and hopefully we'll start implementing as baby steps. At least as a pilot project, definitely. We're going to try and implement all of these.
Thank you, Christina. Nice to hear the presentation, and you just to share that Christina was one of our colleague a few years back, and really happy to see her here with all the members.
Yes, sir. It's a pleasure actually to talk to you also. Nice to see your presentation. Feels like a family environment to see you. Thank you.
Now, as far as the formative assessment methods are concerned, sir, they can readily be implemented with the next batch itself. But the only thing is that requires is preparation preparation and motivation from the part of the teacher. Once he's prepared, the methods can be readily implemented. Thank you.
Dr. Som.
Yes, sir. Dr. Animesh, sir. Hello.
Dr. Somdata, Dr. Parag here.
Dr. Parag,
Can I?
yeah,
Yes.
sure.
Congratulations to Team Joyful Journey. And let me very quickly come in for sort of good news, if I may say so. Yesterday, the course on obstetric and gynecology was launched in similar line with us. And there, as we know that Avinash Supe sir took the initial lecture. And at the end, Bedi sir also will also, if sir wants to add, will add that Supe sir has mentioned that for all these subjects, whatever material that we are developing, sir wish that we better compile everything together and share it with NMC. So that is what sir felt. Sir, I mean, our enthusiasm and the hard work that all have been going around in all those courses. Supe sir could feel it yesterday, and this is what he actually suggested. Supe sir being the chief of the advisors in the rollout of CBME. If Bedish sir wishes, sir can clarify more on this. I just came to know about this today, so I felt like sharing with us all. So that's also an opportunity, in a sense, a responsibility for us also. So that's what I wanted to share. Thank you.
Thank you, sir.
Yeah, thanks. Yeah, thanks, Dr. Parag. That's definitely a wonderful news. Yeah. So, Dr. Pankaj sir also had asked that, like, why you have not included the other skill parts, like Dr. Rupesh or Dr. Christina. You want to answer that part? Like the first part of Dr. Pankaj sir's question was like only like a part of the skill was included, right?
I'm sorry, ma'am, I didn't get the question actually. Is it managing dehydration after assessing dehydration? Is that what we're talking about, or other skills in general?
Dr. Pankaj sir, you want to ask the question again to the group, like the first part
No,
of the question?
no. Since I joined late, I just wanted to know among all the techniques, other than the internship, there was any other psychomotor skill, either for first year, second year, or third year MBBS or elective, or it was the only one? Because my worry is as we go too much on the intellectual skill, though intellectual skills are equally important, we should not become a department which can be taught in the demo halls and lecture halls, and we are not coming out of that. That's only a fear factor.
Yes, sir. In formative assessment, Dr. Rupesh had mentioned about case-based MCQs and case-based discussions also. So that was included.
No, Dr. Christina, let me answer. Dr. Pankaj sir, actually what happened, this group actually was allocated for the skill assessment, only the internship workplace-based assessment. They were specifically told, Joyful Journey group, to develop question from that part. So that's why they have not included other parts for the skill assessment. Right, Dr. Christina, am I right?
Okay, madam.
Absolutely right, ma'am. You're absolutely
Yes,
right. So multiple assignments were posted on 17th November, but our group was given workplace-based assessment during internship. It was a very specific assignment for us.
Right,
Thank you.
right. So I see some questions in the question box, so I'll just read them.
Just again to give a difference of opinion and making the discussion with all difference of opinions and richness to bring, so that because the differences will evolve the science. That's my personal opinion. If we go to the logbook, though we call it a skill, but again that will be a skill which will be can be done at a microscopic level. I am looking where community medicine goes out of the demo hall, lecture halls, and being a clinical departments, to look at the field level training and all the things, because unfortunately or fortunately many of the skills in the form of a simulated environment can be done in the college building itself. We need not go to anywhere. That is the reason of asking that question, because that logbook, again, though it comes in S and SH, but there are multiple ways by which we can improve the quality of that skill training as well as skill assessment in a formative assessment. Maybe field level assessment will be difficult at a summative assessment, but nobody can say any doubt, because these are all minimum requirements even if you want to take it at summative assessment higher level, provided students are trained. Sorry to interrupt you, madam.
Definitely, sir. Thanks for your comment and on the logbook. And somehow the next question is also on logbook. Dr. Ankita Jacob is asking, the part presented in the logbook looks more like a topic in record. This is knows domain, neither shows or knows how. Kindly clarify. Dr. Neha, would you like to answer this part?
Ma'am, actually, in the CBME document also, it has been documented as a skill domain and not knows. So we are asking the students to actually, maybe go out in the field and look for these breeding sites, and there is some skill involved while they are, looking at under the dissecting microscope and trying to identify the features, the specific genus of the mosquitoes. I felt that.
And Dr. Neha, if you remember, we had the same discussion yesterday.
Yes.
And
Yes.
yeah, so we were also wondering, now this is very relevant for the record book. Is it relevant for the logbook? So what we concluded was that now this particular topic, this vector identification, distinguishes us from the other department. Now this is absolutely unique for the community medicine department. Now, if you look at the non-communicable diseases and communicable diseases, there will be again repetition in the clinical departments. Now, this vector identification is unique for our department. So we thought this is a skill that should be recorded in our community medicine logbook. Now, this particular topic was actually discussed yesterday in our discussion, actually, after the presentation. I hope that answers Madam's query also.
Oh, that's fine, Dr. Christina. Thank you so much. And I think I agree with both of you, Dr. Neha and Dr. Christina. So, Dr. Ankita, does it satisfy your question? And are you able to answer you? Hope we are able to answer you. Otherwise, you might comment again. The next question is from Dr. Chitra. If in demography question, student will tell stages correctly, but cannot analyze the scenario, what should we conclude?
So actually, to make the questions more objective, to avoid subjective, problems, we've given marks for each and every part of the question. So that only carries, this identification only carries 2 marks. So if he's done the rest of the part correctly, he'll get full 6 marks. So the total marks given for that question was 8 marks. Now, if he didn't do the identification of the stage properly, he'll just miss 2 marks. He'll get the rest 6. So that's the beauty of splitting the marks into so many different parts, making it more objective.
Yeah, thanks, Dr. Christina.
Madam, can I come for 1 minute?
Sure, sir. Always well.
Whenever this case-based scenarios questions are there, or where the questions are there, where second question is linked to first, third question is either linked to second or one, or it can be DOPS or it can be OSCE, where the second question is linked to the first kind of thing. If the first question is wrong, even if the second question by fluke chance is correct, the student deserves to be as not 0. I don't know if I'm counting in the form of marks or is a formative assessment I'll consider as not attempted. Now just take the example of, say, first question, you identify a disease or identify a differential diagnosis, and second question is, say, related to some causative factors or some symptoms or maybe prevention or whatever. If my first question of diagnosis or differential diagnosis is wrong, and my second question by fluke comes to same because probably that's the only method in both the diseases, I do not deserve to come into the classification, or if in formative assessment meets expectation, I am below expectation, or if it is a marking form, it should be 0. In OSCE or in DOPS, I do everything, starting from taking the blessing of the patient when the patient enters and finally saluting the patient at the end. But what happens finally, my blood pressure recording is not correct. In that case also I deserve the 0 marks, though I have taken all the checklist and all the things are done. So we need to be very, very careful when the questions are linked with each other. Just we need not go blindly with the marks if the most important aspect of that thing is not fulfilled.
Thank you, sir. You're absolutely right. But here, In this particular scenario, the questions were not linked in the long answer question. They were completely
No,
independent.
Christina, I'm just giving a general impression. I'm not going with this question. Yeah.
Yes, sir, you're absolutely right. You're absolutely right. In general, if they got the diagnosis wrong, they'll definitely get the rest of the questions wrong. But in this particular scenario, we had independent questions, not linked with each other in our long answer question.
Dr. Rupesh, can you just project that slide just for once, just for to make the point?
And that's why to improve the quality of the questions is always better to give a link question so that we can understand how much really linking and decision making or the critical thinking has started among the students, where even our national education policy is also moving, and you must have realized now more and more importance is given to the decision making and critical thinking kind of analytic things.
So this is the question of what Dr. Rupesh is showing. Just wanted to clarify the discussion of what was going on between Dr. Pankaj and Dr. Christina. So for others to see. Till now, as still I am waiting for more questions from the participants. May I ask Dr. Manjunath sir for his comments? Dr. Manjunath sir? Okay. Somehow I'm not able to hear sir. Dr. Amir, are you there?
Dr. Amir, are you there? Hello, Dr. Sumita.
Dr. Amir, can you
Hello,
help
am
me
I audible?
You are Dr. Amir.
This has been a very good presentation. I am very impressed, given the shortage of time that this group had, and yeah, sometimes we do the task just for completing the task, and sometimes we put our heart and soul in it. When I was looking at the presentation, I could feel कि बहुत दिल से किया गया है ये पूरा जो exercise develop kiya gaya. This is like they have done it with all their heart and soul. So I congratulate the whole team for an excellent beginning for the second assignment set part, and you have set a new benchmark for the coming presentations, I must say. Just a few comments. One is about the DOPS. In the DOPS, what I could see was there was 12 or 13 items checklist, and each item has got 3 categories for scores. So 3 into 12 becomes 36. And so this assessment feasibility also we will have to look into. So if you, I will also tell that what all things can be looked into, especially like self-introduction, statement of purpose, obtaining, but all these points are important. But at the internship level, we will have to definitely relook at it. This is the first draft or initial draft, I would say, but definitely as when we will go into implementing this, applying it, we will have to be careful that this particular checklist may work or may not work. We should have that thing. And so based on that, how much it is actually feasible in a workplace setting. It's not an isolated place, it's a workplace setting where you do the docs. So 36 things are there, points to be considered in one go. So I think feasibility part will have to look. You can club certain things, omit certain things, and relook at it and do it again. Secondly, I think blood pressure was somewhere mentioned in dehydration in under 5 age group. In the next slide, I think, or next, yes. So I don't think that in under 5 there is measurement of blood pressure. Is it so? Is it somewhere?
It is very much applicable, sir. Only problem is the cuff might not be available in some centers. Now, since it is available in our center, as I said earlier, the rating scale is completely up to the jurisdiction of that particular department. Thank you very much, sir, for your input. As you very rightly said, yes, the criteria are many. The variables are actually 12 or 13. But only thing is that is what differentiates DOPS from an OSCE station. Now, DOPS is something that you do over 15 or 20 minutes normally. So that's what differentiates it from a NOSCI station, and each step is provided with a feedback also. So as you said, this blood pressure, it is very much applicable. So there is a curve that is available for neonates, and there is a curve, and BP is very much applicable, and that is the determining factor, in fact, in ICUs or in the hospital. Only problem is the availability of the curve. So when this point was brought up, that was also discussed. Only thing is that I said, if your particular center has a curve, you keep the point. If your center does not have a curve, you can remove that point. So totally up to the jurisdiction of that particular department.
Thank you,
So
ma'am.
the fall in, yes.
That's an interesting point. We will have to also look at the things in perspective of community medicine. That is also an important thing, that in ICU setting or pediatrics department is one part. What skills are expected with or what are the things regarding assessment of dehydration with respect to community medicine aspect, that also has to be considered. Availability is one part. A community medicine department in some institution may be having certain things, many things that might not be there in other colleges. Just because we have something, it may not necessarily be translated into an assessment for that particular thing. That maybe you may not agree with me. Nobody, it's okay. But I'm just putting forth my point that when we talk of community medicine, then it is important that we have a tab on that what is feasible at the primary healthcare level. That part we should focus more on assessment as the specialized things that may be more relevant for specialized pediatric clinics or ICUs. So that's just a comment I would like to end on.
Thank you, sir. Thank you, sir. I get your point.
Thank you. Yes. And other things, I think it's okay. I don't have any other query regarding this. Okay. Thank you very much, all.
Thank you very much, all. Madam, can I come for short 1 minute?
Sure, sir. Please, sir. Sure, sir. Please.
Can we go back to that question with the case scenario?
Long answer question, Dr. Rupi.
Which was there before Amir sir started. And please consider it as a friendly discussion. Only because we want to evolve our system, that's why I'm bringing certain points. Is not particularly to just critique. Just now, you just see if I'm a student in this case scenario. Okay, now I'm an average student. I don't understand much about the case scenario. What I am losing with? I'm losing only 2 marks because I am not able to identify. But with my intellectual knowledge, I can still write the various stages of demographic cycle, and also I can give example. That means out of this 8 marks, 6 marks are only for my theory knowledge, and 2 marks also only applies to case scenario. So probably we can improve the question in such a way that when case scenario is given, it should not be only for the 2 marks, and it can take larger proportion of the marks, unless otherwise what will happen, the so much of efforts which are taken for developing a case scenario may not serve the purpose. Please consider as a friendly discussion among ourselves.
Fully agree with you, sir. Definitely. That's a very good suggestion. And I think like we can improve on the question and then like work on the Google Doc, like following sir's advice. Thanks, sir.
Sir.
Anybody, any other facilitator for any other comments, please? Because in the question box, I don't see any questions. Dr. Animesh, sir, do you want to comment, sir?
Thank you, Dr. Samyata. No, I don't think I have any particular comment. I think good discussion, and Dr. Pankaj has also given valuable suggestions. And thank you, Dr. Amir, for giving very practical tips. Thank you. And I, of course, want to compliment the group for doing a very good work. And they have really done it well and presented, as Dr. Amir rightly said, Dil Se.
Yeah, thanks, thanks, Dr. Animesh. Dr. Parag, you want to share something, Dr. Parag?
Thank you, sir.
Yes, Dr. Sundata, with regard to the DOPS, just I'll share what I feel that the workplace-based methods such as mini CX and DOPS, I feel that they would be more, I mean, with regard to global rating scales kind of a thing, rather than having a checklist with pinpoint different steps for a particular procedure. So even if you see the literature, the most of the things that I have referred, they are very common formats for mini CX as well as for DOPS. And depending on the situation at hand at workplace, when a particular student is being assessed, it would be free. I mean, teacher would be free to decide what particular aspect to assess on those fixed points on the checklist. If we go too much into the detail and identify the individual steps of a particular procedure or process, probably to my understanding, it would go more towards OSCE rather than DOPS. That's how I see it. I might be wrong, and I'm willing to read more about it and get back to this in the next presentation.
Right, Dr. Parag, thank you so much. So Dr. Mithila has made a comment that agree with Dr. Amir regarding identifying with signs and symptoms and management at a PHC level rather than with equipments, blood pressure equipments. Dr. Himangini ma'am, you want to comment, ma'am? Himangini, Dr. Manjunath sir.
Hello. Good evening, madam. Can you hear me? Can you hear me? Hello. Hello.
Yes, we can hear
Yes,
you.
sir. Yes, sir. We
Yes,
can.
sir.
Yeah. Good evening, all. Good evening, joyous journey team. First of all, I would like to compliment and congratulate all the participants in general and the facilitators in particular for starting this second cycle of presentations. And Amir sir told दिल से क्या है. I would like to add दिल से और दिमाग से दोनों से बहुत अच्छी तरफ से पेश किया है आप लोगों ने.
Thank you, sir. Thank you so much.
Coming to the specifics, generally the public health specialists are always in confusion all over the world, because whether we are hardcore clinicians or whether we are people trying to interpret data at a higher level, trying to make conclusions out of the data presented to us, and trying to make certain interventions at the higher level, including the policy level. This is something which is always being debated around. So in that perspective, and if we look at the hardcore skills part, it is required, whether it is at the whether we assess the skills or the clinical skills is assessed at the field level, where we don't have any facility, or at the primary or secondary healthcare facility level where we have adequate facility, or at the ICU in a tertiary care center we have augmented facility, or all the highest level facility. So these are the three settings where all skills can be assessed. So community medicine person is the only person who can assess skills at the first and second level, maybe sometimes at the tertiary level tertiary setting level also. So I would congratulate the team for thinking of DOPS at the internship level. Though the intricacies of developing a rating scale are still debated around the globe. You have done a great job, and the nitty gritty are adding or taking out some component, as Amit sir rightly pointed out, can always be debated around, and we can, as Madam Christina Madam rightly said, the jurisdiction of that, it can be institutionalized. At the institution, we can decide as to what could be the structure, or the elements or the components which go into the rating scale. But I would like to congratulate that you brought in DOPS into community medicine. Otherwise, DOPS will not come. Otherwise, I was always thinking about, should we develop some scale which can be exclusively the property of public health specialists or community medicine people. So we are, whenever people developed these tools like OSCE, OSPI, DOPS, Mini CX, they were keeping the clinical scenario in mind. No, nobody had kept the field scenario in their mind. That is the problem. That is why you always land up in problem. So I have a plan that we should develop a tool which can be used at the field level. So I had this OSCE. I wanted to present it in Belgaum, but I could not make it. Objectively structured community health examination. So in a primary health center, that is equivalent to OSCE. So where we can use this tool and claim that this is our tool, where we use this in a PHC or in an Anganwadi or in a sub center, this or even in a family setup where we are going for medico-social or clinico-social case studies, this can be used. But until we have a tool of our own, that is what I would like to say. We should make the best use of all other available tools, and DOPS is more of a subjective tool, as Parag sir rightly pointed out. Here we are not worried much about the objectivity. The individual assessor can decide whether the student has done the performance adequately or not. So this is a great effort. So I'm very happy about that one. Coming to the long answer question, so this is again an issue. See, when we are looking at these kinds of questions, we should also keep in mind the kind of students that we have in all the 591 medical schools of India. See, now this question can be modified in various ways. So the first, as Pankaj sir was rightly pointing out, when there is a sequential questions where the second and the subsequent questions are dependent, are derived from the first question, then it is an all or none phenomenon. Either all are correct or all are wrong. But here it is not an all or none phenomenon. We have a question number 1, which is independent of question number 2 and 3. This is always acceptable. But if we can make the second and third question derived or dependent from the first question, then it makes much more sense. There is no doubt about it. So we can say that the second question, when will this city or country will transition to the next stage? What are all the vital indicators? How much it should change, or what interventions need to be done, or what are the problems that the country can face if the country continues in the same demographic trends. Like that, if we have the second and third questions which are related to the first question, which becomes a better question, that is fine. So I would like to, but by and large, I am very happy with the entire content presented today, given the situation that we are in community medicine. So coming to another question, which was the billion-dollar question, what Pankaj sir told in the initial phase, that is, how do we think, or how confident we are that we are able to implement whatever we presented today? This is the question that we should all introspect and ponder over. So I would say there are 4 stages of implementation of this change. One is we will not implement, no implementation at all, or partial implementation, or optimum implementation, or total implementation. So we can think, and madam, I think Christina madam very rightly said, baby steps, learning curves, wonderful terminologies madam used. So it is, we cannot say that we will be able to do full justice to this CBME. And today Avinash Supe sir gave another talk on FFF platform, and sir was also telling the same thing, Supe sir, that it is not that we are able to make a grand change, a dramatic change. Probably we will make some partial implementation in some areas and see and progress over a period of time, and then we will move towards the optimum implementation, and the time will come where we will say that we have done justice to the CBME. And from the teachers and students side, there are three degrees. There are three stages. One is indifference. Indifference. Students are indifferent. Teachers are indifferent about the logbook, about the assessment, about the SLOs, about the teaching learning methods. The second stage is involvement. First is we are indifferent. Second one is we involve. Let us see what benefit we derive out of our involvement. And third is immersion. So we should monitor these stages. We should come out of the indifferent stage as early as possible, as soon as possible. And involvement stage can stay there for some more time. But once we are into immersion stage, lo and behold, we will reach the goal. I think I have taken more time. Thank you very much, madam. Thank you very much, Team Joyous.
Thank you so much, sir. It was lovely listening to your comments. Thank you so much, sir.
Yeah, thanks, Dr. Manjunath sir. It's always a pleasure to hear you. So it's a good idea to go to know the objective structured community health examination, which really can be specific to community medicine, which is coming out after the discussions, the community medicine is something which is not preclinical, which has some difference with the clinical. So something which we really can adopt to our disciplines and develop our own sets or the uniqueness which is there in community medicine discipline. According to that, it will be nice to have that type of scales, that type of standards, and with that, I think we are coming to the end of today's sessions. I'll just wait for a minute for anybody, if anybody wants to comment anything. Okay, so thanks to all. Thanks team Joyful Journey, and thanks all the facilitators and all the participants. It was wonderful. A special thanks to my co-facilitator, Dr. Animesh. He was always there to answer in doubts and to help the group. So thanks, Dr. Animesh. Thanks all. So I'll end the session here.